Buenas noches, bienvenidos una vez más a otra blog de El Doctor de Guardia en el Parking Lot. Hoy voy a hablarles sobre psiquiatría y una de las ventajas que tenemos es que no necesitamos tantos libros. En psiquiatría casi todos los diagnósticos se hacen a partir del DSM-5, el Diagnostic and Statistical Manual número 5, recientemente salió, estamos en el 2016. Este diagnóstico nos permite ver un compendio de cuál es el criterio generalizado basado en conferencias, basados en congresos de psiquiatras, basados en todo tipo de presentaciones y de estadísticas que nos ayudan a identificar los trastornos más frecuentes que podemos diagnosticar. Vamos a decir, en el examen se presentan muchos de estos casos y si usamos el DSM-4 vamos a estar en muy buena forma. El objetivo de esta sesión y estos blogs son para ayudar a facilitar comunicación en inglés, de manera que podamos aprender un lenguaje técnico si se quiere. Y bueno, vamos a comenzar. The first case is we're going to talk about a patient that comes with the complaint of I am feeling sad, and the patient is a 24 years old male or man that comes with this complaint, as well as referring us decrease in the interest in pleasure activities, decrease in the level of energy, decrease in the amount of sleep, although sometimes we can see increasing in the amount of sleep, decrease in the appetite, decrease weight, sometimes we can see the opposite, also a sense of guilt and a sense of worthlessness, ideas of worthlessness. The patient does has some suicidal ideas, and in the process of evaluating we also identify the patient having a plan because he actually bought a gun. We realized that the triggering factor in this situation was a breaking up with his adorable girlfriend of 5 years at the college level, and then he is feeling totally in despair, and he simply wants to commit suicide. So when we're doing this kind of evaluations for the purpose of real life as well as for the purpose of exam, we're going to just try to focus in the prevention. What are the tools that we have to help the patient to prevent any suicidality or in some cases becoming homicidal? Now we're going to see in this particular case, for the purpose of doing these tests, the strategy that we should do. Usually we should go to the first sentence and say, the patient is 24 years old man who comes with ideas of suicidality or becomes depressed. Period. Right there we stop. And usually these questions come with several paragraphs, sometimes more than 5 paragraphs, sometimes 10 paragraphs, 2, 3, 4 pages. And we cannot read the whole thing and figure out then at the end how we're going to answer that. By the time we finish reading, we don't even have time to read the whole thing in less than 1 minute, and we have only 1 minute to answer these questions. So the strategy I recommend is to again go to the first sentence, check what is going on, what is the introduction to the case, and from there going and see the what is that this board wants. Usually the question is, what is your next step? So right now you understand that if they ask you what is the next step, we just browse through the answers. We don't memorize anything, just browse through the answers. The answers can be provide adult to admit the patient for observation 1-to-1 in an emergency room for a psychiatric unit, or to provide antidepressant medication, to provide specifically SRIs, selective serotonin reuptake inhibitors or monoamine oxidase inhibitors, or to provide a tricyclic antidepressant. So basically these are the general conditions. You now know what to focus. And now when we go back to the test, when we go back to the actually content of all those pages of information, we can have their laboratory work. We are going to have different elements to actually rule out the whole spectrum. Can help us to identify diagnosis. But we know that they are asking is for diagnosis for a management question. So right now we go to the DSM-4 and we realize when we're reading these questions, we want to see what are the features that identify that help us to classify a major depressive disorder, which, by the way, the management will be admitting into the psychiatric unit for observation 1-to-1. Now, and then we're going to talk about the follow-up and so the subsequent treatment and at the level of the ward as well as the outpatient clinic. But for now, you already have an idea. We do not recommend, I wouldn't recommend to anybody just to try to guess. Go back to the question, try to disclose all the elements, and these are the elements. The patient has a depressed mood stated by himself, or some people can actually come and refer that he is depressed. So that's the criteria. The patient has decreased interest in pleasure activities. So we need to have either one or the other one. And when we have these two key elements, in pleasure activities, decreased interest, or depressed mood referred by himself or by others, right there we have the key elements to make the diagnosis. Now, in the absence of these two, we don't do the diagnosis, but once we have either one, we can go with the diagnosis if we have the other elements, which are, again, the physical activity, decreased psychomotor activity, the energy level, the decrease in sleep or the decrease in the sleep, the habit of the speech, the verbal speech, how accelerated, decrease, the sense of worthlessness, the sense of guilt, even inappropriate will, even delusional guilt, and we go with this element to make the diagnosis. So this is the criteria A, but also we have criteria B, C, D, E. So for example, we also have to have this in the absence of any intoxication. So the patient, that would be the criteria B or C, for example. We also have to have the complete absence of any medical condition that explains this sense of worthlessness, of this depression symptom. For example, thyroid disease, hypothyroidism, or we can say some sepsis, some infections, general infections. We can say some, for example, tumors. And when we have this, we can make the diagnosis. Now, we also have to have this in the absence of schizophrenia or a schizoaffective disorder or a schizophreniform disorder. So this is important criteria. And one of the most important criteria is the absence of any manic episode. Because if these same questions, we identify a manic episode, then the treatment will be specifically for manic. Sometimes we need to do the Haldol. We have to provide Haldol in the treatment of the patient as part of the manic episode. Now, we're going to go over manic in a few minutes, but just to have a general idea that a manic in just one case is almost diagnostic for immediately giving the category for the bipolar disorder. So, what is the time? Usually, for being a criteria of depression or major depression, you have to have these symptoms for 2 weeks. Now, in the case of manic, the symptom only has to be present for 1 week. And by the way, if the person comes with mania, we can actually admit, and we don't need to wait for 1 week to provide the treatment. We can give the treatment right away. So when the patient is admitted, the criteria for mania doesn't have to be extended, which can raise some concern in terms of the likelihood of making a mistake. But again, we go with this as ethical and as straightforward as possible. So then we have this general presentation. Let's change the case a little bit. Let's say, for example, that this case indeed then comes with a mania. So how would be the case? They would say that the person has elevated or explosive or irritated mood. And then that would be just those words trigger us the red flag that tell us that this is probably a mania. Key element, the person usually have very significant decrease in the need of sleep. not because it's working like we are working in the ER or in a parking lot, but actually because the patient simply can spend hours, days and days, sometimes sleeping 1 or 2 hours a day, and go on and go on, and for weeks. Usually the criteria is only established only when we get just 1 week. That's enough for getting the criteria. Okay, so another elements where in general the person can be involved in very risky activities and activities that can be inherently painful for his pocket or for his health, just like involving in sexual activities that can be less than discreet, to activities that can be frankly risky for his health, like jumping in parachutes, things like that, and doing it very frequently, things that can risk his life, potentially accelerating too much the vehicle where he'll go, getting many tickets, getting into spending sprees in the shopping and buying then suddenly 2 cars and 20 pairs of shoes. Things like that, that sounds very extreme, are indicative of a mania. So this is what we put in this context. Usually the mania also has a very goal-oriented focusing to achieve certain goals, which is good, but also this can come at the expense of decreasing the attention for so many details or distractibility in some other areas. So this is in general the elements. So we have depression, we have mania, and we understand that whenever it's mania, and we can say bipolar disorder, and then we can say bipolar disorder type 1 and bipolar disorder type 2. Usually the bipolar, in order to make the diagnosis of bipolar disorder 1, just need the 1 mania. In the case of bipolar disorder 2, we just need 2 years of hypomania, defined by this exceedingly increased period of actually almost like a lot of energy, without reaching the level of this person who doesn't barely sleep 2 hours, 3 hours a day for a long period of time. So this will be again bipolar 1 and bipolar 2. Now also we have to differentiate the grief reaction. Is this, when we read all these pages and pages of information, we try to identify, if when we just browse to the bottom, if they give us grief reaction. Grief reaction is normal reaction to a person who has lost a loved one, and this is considered normal up to 1 year. So if the patient comes with that symptom, that depressed mood or all these features of depression, but doesn't raise to the level of limiting social activities, or becoming psychotic, or becoming despair to the level of impairing the functioning of the individual. By functioning, we mean function at the social level, at the personal level. From the personal habits of daily living, eating, nurturing himself, hygiene himself, all that element, all to the element of interrelationships with other people, that becomes dysfunctional. And so when we have this combination of elements, then we can say the person has escalated to the level of a psychosis. So the diagnosis can be also depression with psychotic features. It can be also, of course, schizophrenia if we identify psychosis, or schizophrenic form, or a schizoaffective disorder. So this is in general the way of the presentation. And now let's focus in another case. Let's say this is a real case, by the way. It was a patient, ML, patient at Lincoln Hospital. She comes because she lost her job. It's a patient who was an executive secretary, and suddenly she lost her job. She was earning like $80,000 and become to zero in a very small period of time. And the person who brings her is the husband. The husband is so-called one of these leaders, Catholic, not Catholics, just a religious leader, that is bringing her. He wants to admit her. Oh, my wife has to be admitted, very demanding, with 2 acolytes, 2 gentlemen also pushing for that. And when I interviewed the patient, I realized that the patient doesn't have any of the features, barely even has decrease in the activity that produce pleasure. This lady, well, has features of sadness, But more than that, the person doesn't have any suicidal ideation, not homicidal ideation, doesn't have decrease in any of this sleep, energy, appetite, etc. So basically, I took the decision, no, you're perfectly fine. And the person was to still admit the lady. And so we have to raise the concern about sometimes even this so-called religious leader is a criticism that they cannot be using the name of the Lord, so-called, to actually press like the person is receiving some kind of punishment or something like that. That would be a theocracy. That would be horrible. That's not democracy. And that wouldn't ever want to reach that level in any society, not just in America. But I'm saying this as a point of bringing awareness that the psychiatrist does has a serious responsibility. In the people that are in training has that responsibility. You that come here to America to learn English and to provide the best of you to the population also have that responsibility. And so just wanted to just leave that parenthesis. Now, in terms of the treatment, usually we try, let's say if the patient comes with bipolar disorder, defined with some psychotic features. At that point, we usually provide, in general, at the emergency room, it can be provided the Haldol, or benzodiazepines can be provided. Also, they call them mood stabilizers. We have to tell the patient the side effects, some of reactions. For example, if we're going to use the lithium, the kidney function test, the liver, the thyroid function test, we have to check that for the patient. We have to let the patient know. We have valproic acid and we have carbamazepine. Those are drugs that we can use. Now, for the cases of depression, we usually have the three sets of families of drugs. We have this TCAs, tricyclic antidepressant. We have the MOAs, monoamine oxidase inhibitors, and we have the SSRIs, so selective serotonin reuptake inhibitors. Now, the tricyclic antidepressant, we have imipramine, amitriptyline, disipramine, clomipramine, all these similar drugs. They do have a problem with the use in the elderly because they have some anti-muscarinic effect, which means that the patient can come with blurred vision, it can come with dry mouth, it can have constipation, it can have urinary retention, all these symptoms, and this is an elderly, so it's not looking well, it's not seeing well, and is confused, and it is depressed, and suddenly falls and gets a hip fracture. So this is not unusual. It hasn't been unusual. It has happened, not unusual, but it has happened in the past that the doctor provides a medication for something which is relatively minor, like sadness, depression, and suddenly it becomes a worse problem. So we don't want that to happen. So we have to actually explain these side effects clearly to the patient. The monoamine oxidase inhibitors, phenelcine, carbamazepine, calbazine, phenelcine, hydrocarbazine, and isocarboxazide. Those drugs are so, I am just even deleting it from my repertoire because whenever we have this, we use these drugs, we have to clearly explain to the patient the association with malignant hypertension. If the patient drinks or eats some of the medication, the food that contains the thiamine amino acid, because it triggers this response. Examples of this food: the wines and the cheeses and some nuts that are rich in this thiamine. So we don't want usually that. Now, the SSRIs usually come with headache. They can produce headache. They can produce sedation. They classically have some side effects, sexual side effect, in decreasing the libido. It can produce anorgasmia. It can even produce priapism in some instances. As a matter of fact, they can be used as a treatment for from patients that have precocious ejaculation. And so a patient has a precocious ejaculation, is depressed or is anxious, bingo, ping pam, ping pong, you hit a home run because you give him a drug that is going to target both of those problems immediately. It's going to help. A particular drug in this case will be the Paxil. Now, so what are these drugs? Usually fluoxetine, the paroxetine, the sertraline, the fluvoxamine, and the citalopram. The fluoxetine is the Prozac, and we usually use it in a dose of, let's say, 20 milligrams, a single dose per oral diary. The maximum dose in a day, it can go all the way to 80 milligrams. We shouldn't give more than that. The paroxetine, the Paxil, is usually presented in doses of 25 milligrams. Usually also give one pill a day, and the maximum dose in the day is up to 62.5 milligrams. And so basically that's it for the day. The sertraline, the Zoloft, is usually presented in doses of 50 milligrams, and we usually can increase it up to 4 pills a day, at the maximum dose per day. The fluvoxamine, the Levox, usually comes with a dose. We can give also a dose of up to 200. Usually 100 milligrams is a single dose, up to the maximum dose of 200. And the Celexa or the citalopram, usually it comes in doses of 10 milligrams. So usually we can give the maximum dose of up to 40 milligrams a day. Now, one of the frequent elements of the PCP, the primary care provider, is to provide a single dose that sometimes is too small. And as a general principle, what we recommend is to actually increase the dose. Do not change the medication, because then the patient is getting one drug and then it's the next drug, and then suddenly we run out of choices. And there are new drugs coming out, but again, the new drugs are sometimes not the best drugs, because I have drugs that has not been tested with many patients in the side effects, and we don't know if there are some new kind of side effect that we didn't foresee before, and it's coming. So I would rather use a tested drug that have been in the market for a long time. We know all the side effects, rather than being changing. So again, when the patient comes, instead of changing the drug, we would rather increase a little bit and recommend increasing a little bit the dose to help the patient. So basically this is it. I hope you like it and find it interesting. It can be helpful at the time for doing our test here, and this is all for now. Until tomorrow, have a wonderful and great day. Thank you very much for watching. See you tomorrow.